Abdominal physical exam. Abdominal physical exam is performed in this order: inspection, auscultation, percussion, palpation, as applicable. The focus is on going from least invasive and moving through to most invasive. Abdominal inspection includes inspecting for the presence of distension, discolorations, pulsations, and specific signs such as Gray-Turner sign and Cullen sign, especially in light of what the physician may be suspecting. So with the distension, if we see abdominal distension, one of the first differentials are probably going to be considering the presence of a bowel obstruction, for example. Discoloration. Do we have redness, ecchymosis, bruising, cyanotic presentation, paleness, and documentation of those findings? Pulsations. All right, especially on a smaller person or a thinner person, I would anticipate seeing a pulsation over the abdominal aorta. Do we have pulsations elsewhere? We document all those findings. Now, Gray-Turner sign is the presence of ecchymosis or large bruising of the flanks, i.e. the costovertebral angles, and this sign will typically develop within 24 to 48 hours with the onset of an acute pancreatitis. And this sign is usually predictive of an acute pancreatitis as it develops. Cullen's sign is the presence of ecchymosis around the umbilicus, and this sign can develop with pancreatitis or hemorrhagic peritonitis. Here is an example of Gray-Turner's sign. Here is an additional example of Gray-Turner's sign. Here is an example of Cullen's sign. Now the next step would be abdominal auscultation. Now remember, active peristalsis or a normal pitch presentation, when it's present, suggests a non-surgical problem in the presence of an acute abdomen. So there's probably no obstructions, maybe a gastroenteritis, but it's usually a non-surgical problem. Now, the presence of high-pitched peristalsis or borborygmy, and borborygmy is defined as sounds that are produced by fluids and gases being forced through the intestines. Now, this presentation with this higher pitched sound is going to suggest like an intestinal obstruction, because if we have a major narrowing of an area of the intestines, the smaller lumen is going to increase the pitch of those bowel sounds. Now, the presence of severe pain with a silent abdomen, no bowel sounds, indicates a peritonitis. Also, if we're dealing with severe back pain and the patient has signs and symptoms of shock, decreased blood pressure, weak pulse, now we have to be concerned about a possible ruptured abdominal aortic aneurysm. So abdominal auscultation drives a lot of our exam in this area to better ascertain the severity and our differentials. Abdominal percussion is used to evaluate abdominal organs for their size as well as their tissue consistency. And we have to keep in mind how we would anticipate the changes in our findings from a solid organ versus a hollow organ. It also allows the examiner to evaluate for the presence of or changes of normal and abnormal accumulations of fluids or air within the four quadrants of the abdominal cavity. With abdominal palpation, we want to begin with light palpation, and if there is a specific area of pain, we want to start with light palpation away from the area of greatest pain. And we want to focus on detecting areas of particular tenderness, as well as areas of guarding, rigidity, rebound pain, changes in tone. All right. Alright, so we're going to move into some conditions now, starting with acute perforation. Acute perforation is defined as an abnormal opening in the bowel wall, which causes the contents of the bowel to spill into the normally sterile abdominal cavity. Now, any part of the GI tract may become perforated from a variety of causes, and this will release gastric or intestinal contents into the peritoneal space. So when this occurs, in terms of how it would change items such as bowel sounds, we would typically not have bowel sounds developing or present distal to the perforation, because if the contents are being dumped out into the peritoneal cavity, then we're not going to have contents in the GI tract distal to the perforation. Therefore, we're not going to have distension of the GI tract. We're going to have a lack of peristalsis occurring. Therefore, no bowel sounds. Common symptoms that are seen in all types of perforations include nausea, vomiting, and anorexia. Now, in addition, when we look at esophageal, gastric, and duodenal perforations, perforations in these areas tend to present very suddenly with an abrupt onset of acute abdomen, with severe generalized pain, tenderness, and peritoneal signs. The pain may actually radiate into the shoulders from these areas. Now, when there are perforations of other GI areas, these occur usually after there's been some other inflammatory condition. And typically the perforations from these are very small, so the pain may tend to develop more gradually and be a little more localized in its presentation. In the presence of an untreated acute perforation, signs of shock eventually develop. So here we're talking about a life-threatening condition that occurs when the body is not getting adequate blood flow to the organs. We can see multiple organ damage and failure. So diagnosis of acute perforation is usually made by the presence of free air in the abdomen on x-rays. Types of perforations include gastric or duodenal perforations, perforation of the small intestines, and then perforation of the colon. Gastric or duodenal perforations are usually the result of peptic ulcer disease. Small intestinal perforations may arise from trauma or from acute appendicitis or perforated diverticula of the small intestines. Perforated colons can arise from obstruction, diverticulitis in the colon, ulcerative colitis, Crohn's disease, or spontaneously. Treatment is typically a combination of possible antibiotics and/or surgery. This is going to be driven by the severity of the presentation, the size of the perforation, patient presentation. Keep in mind when an acute perforation occurs, we have the initial presentation of the GI contents being dumped into the peritoneal cavity. We typically have an initial chemical inflammatory response that develops within the peritoneal cavity, and it's a localized inflammation. As the intestinal organisms proliferate, we eventually typically develop a secondary bacterial infection. And that's what drives our treatment protocols for this. Appendicitis. Appendicitis is defined as the acute inflammation of the variform appendix. This typically results in abdominal pain, anorexia, and abdominal tenderness. Now, if you'll recall, the appendix is a closed-ended, narrow tube that attaches like a worm, or a variform, to the first part of the colon, to the cecum of the colon. The inner lining of the appendix produces a small amount of mucus that flows through the appendix and into the cecum. The walls of the appendix contain lymphatic tissue and is part of the immune system for making antibodies. The walls of the appendix contain muscles. Now, appendicitis is thought to result from obstruction of the appendix lumen, and this can be either by lymphoid hyperplasia or a fecal lith, which if you'll recall is a hard stony mass of feces, or blockage by a foreign body. Ultimately, the obstruction is going to cause distension, bacterial overgrowth, eventual ischemia, and inflammation. This slide and the next one are illustrations of an appendix. Here's an example of a fecal lith within an appendix. If appendicitis is left untreated, necrosis, gangrene, and perforation occurs. The classic symptoms of acute appendicitis include epigastric or periumbilical pain, followed by a brief period of nausea, vomiting, anorexia, and after a few hours, the pain then shifts to the right lower quadrant. The pain will typically increase with cough and motion. Now please note, this classic presentation occurs in less than 50% of cases of an acute appendicitis. The classic signs of appendicitis include right lower quadrant pain, a positive McBurney's point, a positive Robertson sign, positive psoas sign, the presence of an obturator sign, and then the presence of a low-grade fever. The low-grade fever is going to run around 100 to 101 degrees Fahrenheit. With Robertson sign, this is where on palpation of the left lower quadrant, the patient has an increase in pain on the right lower quadrant, and this is indicative of an appendicitis. Now, psoas sign is the presence of increased pain from passive extension of the right hip joint. Okay, again, extension of the right hip joint. Easiest way to do this is put the patient on their left side. The physician stands behind the patient, stabilize with their left hand over the right SI, and then use their right hand to passively extend the right hip. That will cause an increase in pain with the positive psoas sign. Now, here's an illustration of where McBurney's point is. So basically, a positive McBurney's point is the presence of rebound tenderness, okay, over the right side of the abdomen, and it's about 1/3 of the distance, medial and superior from the ASIS, and 2/3 of the distance from the umbilicus, inferior and lateral. The obturator sign is the production of right lower quadrant pain upon passive internal rotation of the flexed right thigh of the patient. So as this illustration reflects, on the right side, it shows the patient positioning. Patient needs to be supine, take the patient's hip into flexion and the knee into flexion, and then passively internally rotate that hip. With that passive internal rotation of that hip, it is going to stretch the obturator internus muscle. So please look at the illustration on the left now. And this reflects where the inflamed appendix is, and you can see fibers of the obturator internus muscle overlying the appendix. And the obturator internus muscle is attached onto the posterior aspect of the greater trochanter of the femur. So when you take that femur into internal rotation, it is going to stretch the obturator internus muscle and put contractile forces or stretching forces, excuse me, all over that appendix, and it's going to increase the pain. Additional symptoms of appendicitis can include right-sided rectal pain, and additional signs can include right lower quadrant hyperesthesia on examination. Now, in the United States, acute appendicitis is the most common cause of acute abdominal pain requiring surgery, and it's the second most common abdominal surgery after hernias. Now, appendicitis can occur at any age, but it's most commonly seen in the teens and early 20s.